Thank you all for coming today. I'm certainly excited to be here. My name is Peter Winston. I'm Executive Vice President for a company called Synermed. We're here based in Southern California, Los Angeles. We are a managed care organization that focuses our efforts on government programs. About 95% of our business is managed Medi-Cal. And we just recently hit the 1 million mark. So we have 1 million capitated lives under management. So I know a little bit on the subject that we're going to talk about today. The topic is going to specifically be on population health as it relates to Medi-Cal. The perspective that I come from is a little less of, I'm going to do studies, and I'm going to do research, and I'm going to go ahead and publish. In the managed care world, it's all about, I'm getting capitated dollars. The money is now in my checking account. It's what I call sphincter-inducing moments, because what I am now responsible for is writing the checks. So if it's going to be my money that's going out the door, the question is, how do I make that money last as long as possible? And so, focusing on population health, we start dealing with some of those things. So we start off, this is a slide, sometimes I'll talk for an hour and we'll never get off this slide. I've heard it in several different presentations, this is our version of it. When the Affordable Care Act was introduced, and the first thing that came out were the ACOs, the Accountable Care Organizations, hospital and health plan executives stood up and said, so let me get this straight. You want me to go ahead and create systems that's going to reduce my top line revenue by $50 million annually in the hopes that I'm going to get a $2 million bonus at the end of the year. And that's correct. But when it's your money, you're reducing the top line revenue, and that money becomes savings that you're able to reinvest in system redesign. So, when you take a look at a slide like this, most folks, if you're a hospital exec, it's the heads and beds. If you're a doctor, it's going to be making sure you have enough visits in a 24-hour, in an 8-hour shift or a 10-hour shift. You're going to see those patients. So your foot is going to be clearly on the pier. But when you start talking about accountable care, you start using your own money to pay for certain things. That's the managed care side. So you're going to put your foot on that boat. And all is well and all is balanced and life is good until the boat starts leaving the dock. And the further it gets away from the dock, the conundrum really starts to hit home. Because the health plans are the sharks in the water, they don't care about you. If you fail, they'll just get some other sucker to sign a contract and move the patients over to them. So it really doesn't matter. What we want to do is figure out how to avoid the sharks. And so there's companies out there, whether you're a commercial delegated group like a Brown and Toland or something like that. We have a number of Medicaid delegated groups that we deal with on the Medicaid space, or you do in the senior space. Everything is the same thing. You need analytics to know where you're spending the money, and if it's your money, now you got to figure out where you're going to spend it. So where we focus is on the two pyramids. On the left side is really traditional population health. That is, the bulk of the population is relatively healthy. Most of the people in this room would hopefully subscribe to that. We exercise, we don't drink excessively, right? We take our breast exams after age 40, our colonoscopies after age 50. We're doing the things that we're told that we're supposed to. We self-manage ourselves. Of course, beyond that, you then get people who have diseases, and those folks are more costly. So on the right side, the upside down period, we have this bulk of the population, they don't cost a lot. In the middle, you got people who are sicker, they're going to cost more, right? And at the top of the left side period are the really, really sick folks, and they represent the bulk of the expenses. Think the 80-20 rule for simplicity. 80% of the costs are attributable to 20% of your patients. So why are we spending all of our time with check boxes and HEDIS measurements and things like that, when really what we need to focus on, because most of that is going to be self-managed, what we want to focus on is dealing with that top 1, 5, 10% of the population, because focusing on that's going to give us our biggest return on investment. We talk about patient-centered care. The thing is, everybody agrees on patient-centered care, but it's how I define center. If I'm a doctor, it's all about how the patient relates to me. If I'm the hospital, it's all about how the patient relates to it. If I'm the health plan, they're a member. The problem is nobody's talking to one another. And if you really want to talk about patient-centered care, you've got to bring all the pieces together. And it's really from the patient's perspective, what is it? And until you have those conversations between health plans, doctors, and hospital executives in the same room, you're not going to get anything done. I focus on Medicaid. A lot of what's written is on commercial and senior. I deal with the folks that nobody else wants to deal with. And Medicaid is not vanilla. It's not one size fits all. It's not one flavor. There's all kinds of stuff. I mean, yeah, we can talk about seniors and all the stuff that goes on with them, and we can talk about Blue Cross versus Aetna on the commercial side. Medicaid is a whole different ballgame, and all of it requires paperwork. In fact, even how the state of California rolled things out is crazy. Some cases you'll have 2 health plans, some cases you'll have 5 health plans, some cases you have 1 health plan. They're all rolled out differently. They all have different rules in different parts of the state. So, to start a conversation about population health, the first thing we need to do is sort of, where do we come from, where are we going? So, Medicaid Managed Care started in the mid-1980s. We call them primary care case management, PCCMs. You might have heard the term. This is where some Medi-Cal clinics actually had a contract with the state of California, what's now the Department of Healthcare Services. And the Medi-Cal clinic would receive a capitation payment per member per month for 5,000 lives. And then they would be trying to reduce hospitalizations. The department, DHCS, was the health plan. And if there was money left over, the DHCS would actually write a check to the doctor group for keeping down hospitalizations. They actually gave the doctors a share of the savings. In the early 1990s, the state of California said, this is such a great program, we're going to get rid of it. We're closing it down. Right? Doesn't that make sense?
Of course.
What we're going to do, though, is we're going to shift it. We're going to keep the managed care piece. We're just going to get rid of the PCCM piece. So we're going to put it into the HMO. So we're going to go and get health plans to step up to take the risk on these patients. You know, it's basic. It's a checkbook issue. It's open checkbook syndrome. Medicaid fee-for-service is an open checkbook. Any patient can see any doctor. They bill the state. They get paid. There's no controls on utilization, coordination of care, anything. But once it's in a health plan, the state is paying a premium. It's a fixed cost. The state has no further obligation. And so in the mid-1990s, 1997, they started to transition patients, Medi-Cal beneficiaries, into managed care in the state of California. So 1997, the TANF population, temporary aid to needy families, your welfare moms and their kids, all came over. Represents about 50% of the Medi-Cal beneficiaries in the state. It's also the low-hanging fruit, because if it's pregnant women and children, you're not really dealing with significant pathology. It's easy risk. And lots of new medical groups and IPAs actually stepped into this business because the existing medical groups didn't want to take it. Okay, the Facey's, the Brown and Tolans, the Mills Peninsulas, name the group. If you're doing commercial and senior, you didn't want to talk about Medi-Cal for all the classic reasons. They smell, they're non-compliant, they bring 15 of their children in with them at the same time. How many bad things have we heard about Medi-Cal? Okay, some of it's true, not a lot. And they deserve no less than any other. Oh, and they're going to squeeze out all my paying customers. But the fact is, they deserve the same level of health care as everybody else. How are we going to do that? So 50% of all beneficiaries came in the mid-1990s. Flash forward about a dozen years. Affordable Care Act gets passed, and the state of California now, and starting in 2011, starts saying we have another 50% of patients that we still have this open checkbook. Other states have done this, we should do it too. We're going to start moving some of our other cohorts within the Medi-Cal business into managed care. So the first one they started moving in 2011, 2012 was the SPD population, seniors and persons with disabilities. It's also something in other states, it's called ABD, age, blind, and disabled. These are folks that maybe are over 65 but don't qualify for Medicare, only Medi-Cal. These are folks that are disabled, so they're running around the streets in their power wheelchairs and things like that. These are sick puppies. And the question is, who's going to take care of these folks? So they transitioned all them patients from a open checkbook to a premium-based, fixes another problem for the state. Now the health plans have this, and now they've got to deal with the pathology that's now been put into the group. Think about all that. 2014, as part of the implementation of the Affordable Care Act, two things occurred. Number one was getting rid of the Healthy Families Program, which is the SCHIP, the State Children's Health Insurance Program, and because it was a standalone program here in California, so they rolled that into Medi-Cal. And then in January 2014, they then also have Medicaid expansion. And I can tell you that was significant because my enrollment, the membership that we're responsible for, grew by 40% over 12 months. Talk about rapid growth, okay? I was on a hiring binge like you could not believe. And currently in 2016, there's actually a new cohort that's coming in. SB 75 was passed into law, and as part of that, we're going to see about another 120,000 undocumented children who will now be eligible for full scope Medi-Cal. So in Los Angeles, I believe it's about 40,000 lives. The rest are spread out throughout the state. And I can tell you from my perspective, we represent about 10% market share in LA County, so I'll get between 4,000 to 7,000 additional lives, just kids. Now, if we're going to talk about the problem that exists, we need to talk about the delegated model, which you may or may not have heard of. And the delegated model is the model that we created. It's a California fabric. We created this. Back in the 1980s, when the health plans were starting along the way, health plans were making the decisions. The pundits still say it today, we don't want insurance companies making decisions, right? So the doctors in California came around and said, tell you what, give us the money. Let us, as doctors, make the decisions. And we'll prove that we're good guardians and trust for this. And they did. And they did a damn good job. In fact, what we did is, you take a look for the Medi-Cal model, you've got the state, Department of Healthcare Services, rolls down to the health plan, the Knox-Keene health plan, and then for the most part, it rolls down to the IPA or medical group. They get capitated for professional services, and you've got a shared risk pool or an institutional pool or a capitated hospital that's responsible for other services that make up this managed care dollar. What's excluded, if you look at the right and the left, is mental health and substance abuse, right? You have mental health parity, but nobody wants to talk about it. Okay, and MLTS, managed long-term supportive services, and long-term care, which is also not included. It may be included in the premium, but is not included in the basic model that we're talking about. The downside is we became victims of our own success. We did a terrific job of bringing in the hospital services and bringing in the professional services. But in the process, we created silos of our own. The doctors only care about the doctor stuff. The hospitals only care about the hospital stuff. And we've ignored behavioral, substance abuse, and long-term care. And in Medi-Cal, in some cases, they even have their own revenue streams. So it's not like, you can't even bring them together. They're completely separate. In Los Angeles County, I'll get money for professional and institutional, but if it's psych, it's going to the County of Los Angeles, to LADHS. So and then if I pick up the phone, I'm not going to get anybody on the phone. So there's lack of communication, yet when you're talking about Medi-Cal patients, a lot of these folks are going to have behavioral health issues. Some people choose to be poor, some people don't. And and on those that don't, there's usually going to be a substance abuse or behavioral issue that's going to be tied to it. So how do you perform population health in an uncoordinated, bifurcated, delegated, and solid market? Simple. You put the pieces together, just like Humpty Dumpty. You bring the revenue streams back together. Somehow you create this vehicle, so you pull the pieces together, and then once you have, again, control of the dollars, how do you then use those dollars to improve the system from the inside? We start with the care models. So if you look at the care model, the bottom of the care model, you've got primary care and specialty care. These are the existing doctors we're dealing with. And we already know how that works. It works really well. PCPs and specialists handle the bulk of the easy stuff. But then you start experimenting and filling in the blanks. So we'll put in telehealth. A lot of talk about telehealth. So we have networks in the Central Valley. So you got large places, large mileage where you don't have extra people. I can send them on the road for 60 miles to go see a specialist, or maybe I use telehealth in order to get them access to that. So we're creating these interim steps. Ambulatory surgery centers. Does every single surgery need to be done in a hospital? No, none of it can be done cheaper. Again, if it's your money, if it's your checkbook, you get to choose where that patient is going to go. So if an ASC is going to give you a better price than a hospital will, why wouldn't you send it them? Because a lot of them have as good outcomes. Unless you're doing abortions in Texas, argue otherwise. But for the most part, you're going to have as good or better outcomes working with an ambulatory surgery center as you would with a hospital for certain types of procedures. So why not use them? Your community hospitals, they're getting dish funding, so they're going to get some additional money until that funding goes away. But let's be real, we're talking politics. The money is never going away. But we can try some other things as it relates to inpatient care. We actually built a birthing center because we wanted to reduce the C-section rate, right? Improve outcomes. So where's the pushback on something like that? Well, first is going to be the OBs that says, if you're delivering the baby and I'm not, I'm losing $500 per delivery. We said, I'll tell you what, I'll pay you the $500. Just refer the patient over and let our midwives take care of her. And then they said they would, but they would never send the patient. We'd go to the health plans. Well, Medi-Cal pays $1,600. Yeah, but if they're delivered in the hospital, you're forced to pay $6,000 to the hospital for that stay. So why don't we split the difference and you give me $3,500, $4,000 for each one? One health plan said yes, two health plans said no. I went to the state of California, made the same argument. You're paying all this money, we will show you how well we can do. And they said, sounds intriguing. Come back after you've done 500 of these. Well, I did about 200, but I couldn't sustain it, so therefore I had to close it down. It was an expensive mistake. We learned a lot. But if you don't try things, then you're not going to know. So it's not book learning. This is actually experiential, hands-on, make something happen learning. So, and then we continue to go up the ambulatory ICU. We've had our greatest success, and that's what I'm going to spend the rest of the time this afternoon talking about. What we did is we brought together 3 companies to create a joint venture. So Synermed, the company I work for, is the management company. We've got about 1 million lives, capitated lives, the bulk of it Medi-Cal. We said, we'll be the management side of things. We took EHS Medical Group, which is our largest client, with 500,000 lives, 250,000 of them in Los Angeles County. And we said, so we'll bring the revenue stream from that 250,000, we'll bring it in. And then we took the hospital, Pacific Alliance Medical Center, which was capitated for those 250,000 lives. We brought them into the room. So rather than saying I got 250 and 250, I got 500, no, I have 250,000 lives, but I've got the global capitation. I've got the bulk of the premium dollar now under one place. And what we did is we created a clinic, the Downtown Coordinated Care Center. And its focus was on, if you remember the pyramid at the very beginning, our focus was going to be on that top or worst 1% of the population. Your multiple readmissions, your multiple chronic conditions with substance. These are two or more chronic conditions, definitely mental health, substance abuse issues. These are the patients. I got patients when I start reviewing claims, and I have a patient who was seen 1,500 times in ERs over a 2-year period. A drug seeker. We nicknamed her Drugstore Cowgirl. You just go round and round and round. And when you read the medical records, they're wonderful. Nurses love to document. So read some ER notes. Fascinating. Mabel came in today. We wouldn't give her her drugs, so she went out into the parking lot to smoke a cigarette until the next shift. When we looked at the claims, it's like, okay, she's going from hospital to hospital. Understood, a lot of these hospitals are systems, which means they have shared EMRs. So the patient should pop up on every ER radar when she walks in the door. Yet, when she walks into it, they're all going to do a chest. I had 179 chest x-rays. This patient glowed on the way out the door. And when she complained about not being able to breathe, is it any wonder? These are serious risk management issues for a hospital because most of your ER physicians are under exclusive contract. And they're not spending the time to investigate certain things about the frequent flyers that are coming in. They just hide behind their Intala shield and say, hey, I got to look at everybody, even when you know who they are. So we created this DC3. We identified the patients, the Downtown Coordinated Care Center, and our initial focus was on that 1%. Located on the campus of Pacific Alliance Medical Center, dedicated to providing personalized quality care plans to patients with the most complex care needs. It manages multi-ethnic, multilingual, adult and senior populations with complex and chronic diseases that exceed that of most people. These are not services that are going to be covered in a 15-minute office visit. The problem with this population is that while some people have great support networks, many of our patients have nothing. So the team acts as a surrogate decision maker and supporters to do whatever is medically and humanely appropriate given the circumstances. Basically, if you're a member of the DC3, we throw out the rule book. I mean literally throw it out. I don't hide behind it's not a covered benefit. That doesn't exist. We are totally non-judgmental. You live under the freeway, I'm going to send the hospital van under the freeway to pick you up and take you to the clinic. And at the end of the day, I'm going to take you right back. I'm not going to judge. You need 7 days of IV antibiotics, but you're homeless? Okay, Motel 6 right down the street. We're going to go ahead and book you in. I'm going to have the home health nurse come every day to change your bag. These are not covered benefits. But if I didn't do this, the patient would be back in the ER and back admitted. Can't keep food down because you're wasting away due to AIDS or some other complicated condition? Have a joint, right? We can all get our hands on medical marijuana. How many health plans cover it? All right? But if they can't keep it down, what's wrong with giving them a case of the munchies if the end result is better patient care and you're improving their life? So I'm going to put that to you. Think about that. This is a population in trouble. And it's not just a Medicaid population. It's any population that has multiple comorbidities. How are you treating them? Are you following a rule book? Or are you literally throwing the rule book out? So Synermed's Care Transition Unit, our CTU team, identifies patients based on hospital records. When we know that there's a patient who's had multiple readmissions, and we find out that they're in the hospital, we will send our people to that hospital, work with the discharge planners, and we basically will talk to that patient. Hey, we'd love to have you come in. Our doctors are not on any roster. They're credentialed, but they're not on a roster. You can't choose us, we choose you. So we will go out and look for the patient. The physicians and nurse practitioners, they'll see no more than 5 to 10 patients a day, tops, because of the amount of time that they need to spend on it. Along with the case managers, social workers, they're responsible for care plan success. They identify care needs, they coordinate deployment. All staff are involved in clinical plan development, resource navigation, and coordination. They'll talk to the patients about end-of-life care. They'll talk to the patient about carve-outs, referrals, and appointments. And then we'll work with the social service resources to make sure they get to where they need to go if we're the ones not able to do it. Working with our street teams. We have 2 street teams. We have a homeless street team, providing services delivered directly to patients where they are. Okay, you live in the LA River, we're going to you. We'll bring the psychiatrist with us, we'll do the meds there, we'll do whatever is necessary. We'll treat medical and psychiatric conditions, we'll dispense meds, we'll provide patient education materials. And then we have our homebound street team. These are patients we can't get into the clinic. We will actually bring people, our staff, out to the member's home to do the stuff that we need to do remotely. Again, throw out the rule book. And we can get into the details of how it was organized and what we're doing with it. So let's talk about results. Before opening our doors in 2012, this 1% of the population, Medi-Cal, each patient was costing on average $30,000 per member per month. The premium paid by the state of California was somewhere between $100 and $200 per member per month. I'm losing my ass on these patients. After we opened the clinic and did what we're doing, we've got the cost down to about $5,000 per member per month. Oh, I'm still losing my shirt on this, but I'm losing a lot less. I've got a 6-to-1 ROI because it's my checkbook. Because it's not about book learning. It's about experience learning. And this is what we're doing to take care of the patients. We've had about 1,700 patients go through our doors. 500 remain active. 500 have graduated, meaning they no longer need our services. The rest, you know, if you're not willing to deal with the group hug that we're going to give to you and abide by the rules that we're going to impose, because in some cases that's what these people need is a firm hand. There's other medical groups out there that you can choose. There's other health plans you can choose. I'm not here to fix the entire world, just my corner of it. And so by having modest goals, that's how we've approached the problem. Up on the board, a couple of our websites. So there's more information about Synermed that's on there. There's more information about EHS Medical Group that's up there. You can actually see information about our clinic, dc3medical.com. So you can do that. We have a blog, californiamedicalchanges.com. We've got some YouTube videos out there. You can get past the Gangnam Style Christmas parties, you know, if you want to get to some of the real stuff. But basically, that's what we have for population health in the Medicaid environment. So now, I guess we're open to Q&A.
So you said that some patients weren't able to, you know, kind of accommodate the structure of the ambulatory ICU. They still remain your patients, your members, right? You're still paying for those 500 visits to the ER in 2 years or whatever.
Some yes, some no. You say, look, if you're going to be a member of this group, this is where you're going. You don't like it, here's the 800 number, call the health plan, choose somebody else. Because it's important that you take an active role. If you're willing to do this, it'll be a great ride. We've got stories. I did not bring the clinical pictures. Okay, if you're a nurse, you really get off on this stuff. If you're not a nurse, I'm sorry that we just had lunch, because there is some crazy stuff that we've gotten coming through this place. So it's like wound care for 6 months, starting with open fistulas that are this big. Okay? You're going to come in. You're not going to come in, choose somebody else, because we're going to make you come in. I'm not going to be judgmental, but you're coming in.
And is this for a certain geography? Do you have like a 5-mile radius around the ICU or a 10-mile radius around the ICU for who is participating?
How about all of Los Angeles County? Really? The hospital and the group are capitated for 250,000 lives each. We bring it all together. It's all of LA County because the groups have capitated responsibility for all of LA County. So we work with the hospital to use their hospital van. If you're going to drive out to Pomona to pick one up and bring them in, yep, that's what we're going to do. If I got to go to West Hills, I'm going to do that too. It's all a matter of being able to coordinate the resources. But when you talk about contributions in kind, okay, the hospital contributes the medical office building space. They're contributing the staff in some case. But understand something, they're contributing the staff, they're on the hospital's payroll. I have higher fire responsibility. So Synermed is managing the clinic, even though the hospital is payroll. Now, you think about your hospital systems and things about giving up that kind of control. Who's ready to do that? Because you start getting into the hospital politics, things aren't going to happen. So this was how we needed to negotiate this from the get-go. If we're going to make this happen, okay, everybody's got to be in, and you can't start playing your own little silo on this. In the medical office building, I have access to all the specialists. And every single one of them agreed to same-day appointments. So if I've got a patient and I need to see the psych, we're walking downstairs. If I need to get an x-ray, I'm going to the other floor. If I need to admit you, we're walking across the street. So all of those were things that were pre-negotiated. This is not a revenue generator. It's a cost ameliorator. Because when you think about it, if the hospital is capitated, I'm just going to pick a number, $30 PMPM. I may spend $2 million on this, but if I'm saving $30 million, that's $30 million in profit that I'm not spending everywhere else in the system. It's a good investment. I got a 6-to-1 ROI to prove it. Yes?
Peter, I really have to applaud you for your innovative care model and just kind of totally think out of the box. And I know your population is really the highest risk, low poverty on the street. They have a lot of life traumas. And I'm just curious, how do you recruit a staff and how do you prepare your staff? How do you train them and how do you prevent secondary trauma of your workforce?
It's like anybody, great question, and it's like finding people to work in an ER. It takes a certain kind of individual that wants to work with these kinds of patients on a day in and day out basis, and they become absolutely attached to the patients, and the patients become absolutely attached to them. I mean, you have little alumni events, so do we. And we'll bring the patients in, and we'll have cookies and cake and everything else because of the successes of, are you sober for a little while longer? Or, the sores didn't open up again because you're actually taking care of the sores that led to that open fistula. Those are the successes. So, yeah, it's always a challenge to find that, but they are there. Just look at the people in critical care and ER nursing, or people, for Christ's sake, think about the people who are coming back from the wars in Iraq and Afghanistan. Okay, where are you going to use them if you're part of their EMT teams? Here's a place. So it's not as hard, but it is difficult.
I was going to say, how do you beat back the providers that would want to be on the team? But I'm kind of serious because if I have a set of providers that love to write narrative notes in the EHR, taking care of a safety net population that would love to see 10 patients a day. And I think a number of them are seeing 10 patients a day, but that's another issue. But I guess the question I have for you is, do you need many physicians? I guess what I'm really asking is how much social worker support do you have? How much RN support do you have for every MD or FNP or PA?
So between the outside staff and the inside staff, I don't have the exact numbers, but we do have full complement of nurses, LCSWs, and of course access to all of the support physician personnel that are able to deal with those things. 10 patients a day is nice. Yes, I get that. The panel size is only 500 for the whole clinic itself. So it's not like a standard, if you're a physician FTE, your panel size is 1 to 2,000. And that's why I only have 15 minutes. This is a panel size up, and it's not a question of writing clinical notes for half an hour. You're providing hands-on patient care for that 30 minutes. You've got open sores that you are working. I mean, we're talking about grotesque. I mean, it's like going into the coroner's office for the first time or seeing a cadaver for the first time. You just want to retch with some of this stuff that these people are walking around with.
Well, sure. You don't need a doctor to do that. Other people would do it better. Where's the Dr. Miller? I don't know if she's here, but other people do that better. But I guess what would be interesting to know would be the care team ratios. So, in other words, for every MD, you have 2 RNs, or you have 1 LCSW, or you have 2 medicals.
I don't have that, but I can get that for you.
Yeah, it would just be interesting.
Sure. More questions?
The care team ratio based on patients.
Right. So if we have 500 active patients, I got 1.5 physicians. I think I've got 1 nurse practitioner. We're looking for a 2nd nurse practitioner. And then the question is how many RNs, MAs, LCSWs, the rest of the support team that function within that environment.
Are you a combination of working through paper networks as well as staff model?
So the model that we have, Synermed is the management company. So we contract with IPAs and hospitals that are taking capitated risk. They are my clients.
My question is pertinent. What have you found to be the most effective and fair, although fair isn't high in the beholder, in the whole area of immunizations? When the immunizations are being delivered by the frontline, physician, because you want to get it when you can. But how do you structure or not the risk relationships or the payment methodologies for immunizations in your population?
So there's a couple of pieces to that. First of all, in the Medi-Cal population, understand that for children, the vaccines are free. So there's the VFC program, the Vaccines for Children program. So you sign up, you can actually get all of your vaccines for $0. It costs you nothing to get that. Now the question is, how do you get them to actually use it? And so we pay the administrative fee to actually do the vaccination. So while the vaccines are free, we know that there's, you got to put it in the fridge, you got to take stock, you got to map out the numbers in case there's any kind of a recall. When the patient shows up, you're actually going to give the shot. So in those kinds of things, we'll pay a fee on top of anything else. Some people may say it's included in the capitation, but because we feel vaccines are important, we're actually going to pay for it as a fee-for-service carve-out in addition to the capitation in order to continue to drive that message home. And so, you try to align the incentives. Money talks, bullshit walks, and so we try to align the incentives that says, if it's about the money, I'm going to pay you for doing the right thing, and doing the right thing is giving immunizations. I'm going to pay you for every shot you do.
Most of my life has been on the commercial side, where vaccines were like an insured service, where we did not put the provider at risk for that vaccination because we wanted to promote the delivery of vaccination. How about in your Medicaid, not senior, but adult population? How do you structure that when there are not these special state programs that you have for children?
First of all, VFC is a federal program, so it's available.
I'm new to Medicaid. That's
That's part of why we're here.
So life on the commercial side.
No, let's be clear. I'm here to impart information. That's great. So, yes on that. So on the adults, we'll do something very similar. So you can say it's part of the insured risk, or you can say it's a carve-out that says, I'm going to pay you a PMPM plus, I'll pay you cost plus, I'll pay you whatever the default fee schedule, what does Medi-Cal pay for a vaccine? I will pay you over and above the capitation. So the risk is being taken by the group at the IPA level, and it's coming out of their checkbook to pay the individual doctor for administering those additional vaccines to an adult population.
So in the adult, it's really a contractual issue between the Medicaid HMO and the IPA.
Yes.
Or the IPA and the individual physician.
The entire system is built upon contractual relationships, as opposed to Medi-Cal fee-for-service. You sign an application and up and goes. Although I'd probably tell you that that's also a contractual relationship because it's small print when you sign the form to become a Medi-Cal provider that says, I'm agreeing to do certain things.
And then I I should have prefaced I have an agenda here because I'm involved in an organization advising today where the individual provider is right today is forced to take risk on vaccines, and the PMPM doesn't cover anywhere close to what that cost is if you appropriately vaccinate your adult patient population.
So let me work it back. Let's re-engineer that backwards. If you're collecting encounter data from all of the physicians that are in your network, especially the primary cares that are rendering care, and then you were to calculate the value of the encounters and compare that to the PMPM, because not everybody, when do I go to the doctor? Not everybody is going to go see their physician. So a PMPM, remember that a PMPM, a per member per month, I'm paying whether the member shows up or not. So it's not the value of the PMPM is not covering the cost of this patient. It never will. But in the population, if you've got 1,000 patients, is the PMPM taking care of the 30% that are coming in any given month and the services that are done? So if it's a Medicare, I would use Medicare fee schedule as a default to say, what is the value of Medicare services being provided on a PMPM basis versus what am I paying the doctor per member per month? And as long as they're closely aligned, I've done my job. If they're way out of whack, either I'm getting an extraordinary benefit or the doctor is getting an extraordinary benefit, and those then need to be realigned. And that's an analytics function that I would go back to the IPA and say, this is the analysis you need to look at. Yes?
So with the duals, how does that affect your revenue stream if you're getting some of your revenue from Medicare and some from Medicaid? Are you handling any of the duals?
Duals is a fun subject. So the way the duals work right now depends on what part of the state you're in. So if you're in one of the counties that's operating under the program called Cal Connect, which is the duals Medi-Medi, what they've done is they've combined the revenue streams for Medicaid and Medicare into one capitation payment paid to the health plan. So you're not getting a separate Medicare payment and a separate Medicaid payment. You're getting a single payment that's actually combined for both. Less any of the carve-outs. So long-term care, still at LTSS, long-term supportive services remains with the health plan. That's their risk. Now, I'm waiting to see the first SNF that's going to step up and say, I have a skilled nursing facility, I want long-term care risk. Because that's going to be the disruptor. Is there a skilled nursing facility that's ready to go there? We're having those kinds of discussions. How would you take it? What's the financial model? How does that work? Behavioral health, same thing. But for the Medi-Medis, just understand this, one check. But now you've got all the services. There's no crossover claims. You're responsible for whatever that book of services are, that bundle of services that you've contractually obligated yourself to provide. That includes Medicare benefits and Medicaid benefits under one umbrella. In those counties. In other counties, Medi-Medi, you could have two payments. And the question is, are you in two different IPAs? Creates a bit of a challenge. Medicare pays first, Medicaid pays second. Show me the EOB. If it's under one roof, it makes it easier because I can sort of look in the system and say, oh, it's mine, I paid, we're good. It's one of those kind of things. It does create some unique challenges.
So when your fellow who lives under the freeway comes into the clinic and gets admitted to the hospital, now it's time for him to be discharged. When I worked at the county hospital, there were usually 5 or 6 people on the floor that we didn't have any place to discharge them, so we couldn't let them go. How are you handling that?
Well, maybe I go and rent a motel room for them for a week or two to transition them and then have them come to my clinic during those interim days, like use the DC-3 as a discharge clinic to help transition them back to the freeway. Because if you just send them out, they'll get infected immediately, they'll bounce. But I'll go ahead and create my own step down. Medi-Cal's not paying for that. But the hospital, I'll go ahead, I'll buy I'll get a weekly residential thing and I'll put them up and we'll send the nurses over every day.
And your original diagram where you had under the Knox-Keene, the IPA, the hospital, and you had mental health over here.
Yes.
You're clearly providing mental health and substance abuse, but are you specifically contracting for those dollars?
No,
No.
I have no access to those dollars.
Okay.
So I'm providing again, it's that, if it's my checkbook,
Yeah.
what do I need to provide?
Yeah.
And so even though there's a revenue stream that's going someplace else,
Who's supposed to be doing what you're doing?
who's supposed to be coordinating, okay, we want to talk about whole person care,
Yeah.
then someone's got to pick up the damn phone.
Yeah.
And that's not happening. So until someone does, I'm not going to wait. I'll contract with the psychiatrists or some other type of staff that's going to help me take care of this member today. Because if I send them over there, I lose them. I won't see them for 6 months. I won't have any idea what's going on with them. This is interesting. Over here and over here.
Yeah, I was wondering if you have medications in your calculated rate that you have managed, was that carved out?
Part B.
Okay.
And the medication issue applies to commercial as well as Medicaid as well as senior. You've got the Richmond bill that went through that says delegated IPAs or delegated medical groups that are taking risk can elect to refuse to be on the hook for Part B medications. The problem is it's nice in theory, but in application it doesn't work because what the health plan will do is they'll turn around and say, I may calculate it as worth $1 per member per month, but the health plan will say it's $5 per member per month. And so am I willing to take a $5 cut to not have that risk? Whereas maybe we do something different. Maybe I'll take that risk and work it that way. Part D type of drugs, now there is no Part D for Medicaid or commercial, but it's a shorthand when we talk about if it's a pill. Part D type of risk is usually not held by downstream providers. That's always retained by the health plan.
So your DC3 clinic
Yes.
seems to be an interesting model for like a Los Angeles geography. But I noticed that your counties listed Sacramento, Central Valley, or whatever. Do you think this is scalable? Can you do this type of a high touch in some of these other locations that you're working in?
The answer to the question is absolutely. It is scalable. It may not look exactly the same, but what I need are the partners. So I'm in Sacramento, but can I get a Scripps? If I'm in Sacramento, can I get a Sutter or a Dignity that's willing to kick in a couple of $1 million with the clinic and to give me the control over the staff in the clinic to make it happen?
No.
Not yet. I didn't say no, I just said not yet. If I'm in San Diego, am I going to get Scripps or Sharp to be able to do that? If I'm in Fresno, am I going to get Community Regional Medical Center or Valley Children's Hospital to do that, or St. Agnes? And it also requires the scale. How many lives do I have? So while I have 250,000 lives in Los Angeles with a capitated hospital, in Sacramento I only have 60,000 lives. Well, if I'm going to say it's my top 1%, what is that? That's 600 patients total at any one time. So we've actually gone through 1,700 of my 2,500 to do LA County. If I only have 600 total, what is going to be my ongoing cohort? Maybe 50 to 100. Is that going to be enough to support? I may need to do other things with that kind of a clinical asset. And my time is up. Thank you.